Welcome back to Mapping Healthcare on KDRT 95.7 FM in Davis, California, where a medic with a map explores healthcare around the world, highlights people who improve it, and shares what we can learn from them. This is your host, Dr. Sheikh. In the last episode of Mapping Healthcare, we spoke about increasing access to medically necessary cesarean sections or C-sections. In today's episode, we're dealing with another delivery dilemma: the rising global rates of medically unnecessary C-sections. Once a life-saving procedure, high C-section rates have become a significant public health concern. A C-section is a surgical procedure that, when medically necessary, can prevent maternal and infant issues and deaths. It's a critical tool in modern obstetrics. However, there's no evidence of benefit for women or infants when there's no medical indication for the procedure. So what's considered an optimal rate for C-sections? According to the World Health Organization, an acceptable C-section rate for medically necessary procedures is likely between 5% to 15% of deliveries. So what are we seeing in reality compared to this optimal rate? Global C-section rates have increased dramatically, and Latin America has some of the highest rates in the world. In some parts of the region, C-section rates are almost 60%. So why are high rates of medically unnecessary C-sections a problem? The consequences are substantial for both mothers and babies as well as healthcare systems. For mothers, unnecessary C-sections can lead to increased risks of bleeding, infections, scarring of the uterus, future infertility, and even death. Newborns could have a higher risk of breathing problems, low birth weight, and intensive care unit admissions. Beyond these health risks, medically unnecessary C-sections raise overall healthcare costs, requiring more medical interventions and longer hospital stays. So let's look at what's driving this increased C-section rates. It's a complex interplay of factors related to childbearing women in society, healthcare professionals, and health systems. Let's break those down, starting with factors related to women in society first. For women, reasons for favoring a C-section could include a fear of labor pain, especially if other forms of pain control aren't readily available. Some women worry about pelvic floor damage or urinary incontinence, or they could perceive C-sections as safer for themselves and their babies. Patient preference plays a role, particularly in societies where women have work or family responsibilities. Or women could want to have their tubes tied during the procedure or pick a particular birth date for their baby. Previous negative experiences with childbirth, such as poor quality of care or disrespect or lack of trust in the healthcare system, also influence this choice. Societal norms and media portrayals also contribute, with elective C-sections often presented as more controllable, convenient, fashionable, or modern. And what about healthcare professionals themselves? How do they contribute? The fear of litigation is a big driver. Clinicians are more likely to be sued for complications during vaginal delivery than for unnecessary C-sections, even without error, leading to defensive medicine, where C-sections are performed for professional protection. Convenience is another factor. Many C-sections occur during working hours and weekdays, peaking on Fridays, suggesting that they may be scheduled for the ease of the clinician or the healthcare system. And finally, how do health systems and finances play a role? This is a big one. In many settings, C-sections are higher in the private sector. In places where a C-section generates more income for health systems, there may be financial incentives where clinicians or hospitals persuade women that surgery is best. Our guest on today's episode of Mapping Healthcare is Pedro Delgado, Vice President of the Institute for Healthcare Improvement. We talk about his team's work on reducing C-section overuse in Latin America. The views expressed on the show are mine and those of my guests. So Pedro, welcome to Mapping Healthcare. You grew up in Venezuela and have worked with the Institute for Healthcare Improvement, or IHI, for many years, leading work across cultures, languages, and systems in several parts of the world, in Latin America and now in Europe. So briefly tell us about your educational background and career journey to what you do now.
Ulfa, thank you so much. It's lovely to be here. My educational background and what led me to where I am now is very colorful. And I have to start with my childhood passion, which is sports, because it has taught me a lot around improvement. And it has taken me places. I played for the under 17 Venezuela national team football, and that generated interest from universities in the US. And I ended up with a scholarship there and studied a couple of degrees, including psychology, and then went back to do training in counseling and psychotherapy. So I did a bit of that. And then when I moved to the UK, I moved on to hospital management. And within that, I started to get very, very interested in patient safety and quality improvement in the early 2000s. And from there, it was a non-linear journey to IHI, and from there to the absolute privilege of working with many partners around the world. So yeah, quite a diverse set of background activities, but all people-centered, all improvement-focused, and all kind of with a sense of gratitude and a sense of responsibility grounded on privilege. I didn't grow up in a wealthy family, nowhere near that, but I did have access to a school. I had access to love and attention when I was young, to a loving family, and I was lucky with friends. And those privileges, I think, should be taken with responsibility to try to do something with people where you pass it on, the care, the attention, the love.
And that clearly comes out in your career, Pedro, passing on the opportunities and the privileges that you've had access to the people you now work with in healthcare improvement. So let's talk about the focus of today's episode. So Latin America has one of the highest cesarean or C-section rates in the world. In Brazil, where this project that we're talking about today occurred, about 85% of all births in private hospitals are cesarean. In contrast, in public hospitals, this rate is about 55%, more than half of all births. That's about the same C section rate in Venezuela as well. When your team worked on this initiative in Brazil, what did they find were the reasons for this high C section rate there?
It's interesting, Ulfa, the initial framing for us when we have the opportunity to work anywhere is to ask the local experts, what's it like for you? And to ask the local experts what matters to you, both the service users first, the mothers in this case, and then the professionals for the system to be what it is. And we start with the premise that every system is perfectly designed to get the results that it gets. And the system in Brazil, just like in many parts of Latin America, actually has many wonders, including the wonderful staff and the wonderful services that they offer. But it also has, some challenges. One is there's a financial and time incentive for providers. From a scheduling convenience, it's very convenient to be able to schedule at predictable times procedures that, by and large, can be delivered in a kind of limited amount of time rather than waiting for the natural processes of the body. There's undoubtedly a cultural and social perception around C-sections being modern, cleaner, safer, and it's almost become like a social status for some in Latin America, and Brazil is no exception. And, historically, the quality movement has advocated for having institutional guidelines and having a sense of reliability alongside those. And I think in Latin America, in our history of quality, there's probably been more grounding on autonomy and really, really valuing the professional nature of the health professionals who train very hard to become experts, and that kind of maybe trumping things like guidelines and so on. So there's a consequence of that around training and practice that become norms. So if you have a couple of generations of obstetricians that have been traditionally spending 80 to 90% of their time doing C-sections, it's likely that they'll train the people that come in the next generation in similar ways. So it's a complex issue, but every system is perfectly designed to get the results that it gets. And I think that probably was the starting point in the work that we did in Brazil with incredibly committed people.
From what you mentioned, clearly, as you said, this is a complex issue, it's multifactorial. And that really is what quality improvement is, isn't it? It's just not one cause or one factor, but really looking at the ecosystem of healthcare systems, patients, populations, and looking at the intersection between all of those groups that really tells you what the true picture is. So, high C section rates in Brazil and many other countries in Latin America and in many other parts of the world are associated with socioeconomic status, as you mentioned. So, C section rates are higher in wealthier women and women with higher educational levels. So, how did you adapt your approach for reducing C section rates to these cultural factors and this context and the setting? So, what other factors did you have to consider when planning the implementation of this intervention?
When we started this work, the interest from the organization that regulates the private sector in Brazil, the initials are ANS. They called us because they had a challenge by women that were advocating for something to be done to counter what they felt was obstetric violence. So that was the burning platform at that time in Brazil, was obstetric violence. And when they called us, they invited us into rooms to say, look, we've got guidelines, we've got rules, we've got incentives and disincentives, and nothing is working. But now we have women's movements coming to us and saying there's obstetric violence here. You need to do something. And we're keen to do something. And we've heard about quality improvement being a respectful method where you invite people to express their concerns, have their voices reflected, start where they are, and then move forward. And that's exactly what we did. We gathered with Brazilian obstetricians, midwives, women's groups, hospital leaders. We asked them, how do you feel around the current reality? And if there's desire to change it, what can we do? So once you get into those conversations and people connect with the unnecessarian as we call them there, nature of the high rate of C-sections, then they start to get very creative. So part of it was the individual obstetrician orientation versus teamwork. So there was a lot of kind of conversation and actual tangible changes around how they staff the obstetrics team so that it was team-based rather than individual dependent. And that made a big difference. A part of it was around the physical spaces, rather than having just access to surgical theaters, having access to birthing rooms. Part of it was around holding each other to account and having guidelines that they actually adhere to and having mechanisms to learn when things weren't going in the direction that they expected. And part of it, frankly, was working on changing the dynamic between respecting the woman's wishes and potentially imposing, at times unintentionally, the desires of the clinical team. And I'll tell you one quick story. One of the leaders that we worked with, his wife was having the first baby. He was quite keen on the reduction of cesareans in private institutions as an imperative. And he asked his wife to kind of shout out if she wanted her wishes respected, because she was very adamant that she wanted a natural birth. He went in and his colleague who was in charge of his wife's birth came out after a couple of hours and said, hey, do you think she's ready for a C-section? And he said, no, what did she tell you she wanted? Well, she wanted a natural birth, but it's been 2 hours. And he said, well, you have to respect her wishes. And then he came out again an hour later and said, hey, it's been 3 hours. Are you sure this is what you want for your wife? She seems to be suffering. And of course, he said, my wife expressed to you a desire to have her baby naturally. So it happened 3 times, Ulfat. And I tell you, if he would not have been his friend's colleague, that woman would have probably ended up with a C-section, because her desires would have been trumped by kind of a nudging, intentional or unintentional, of the obstetrician, say, hey, we can stop the suffering. Let's just do a C-section. You'll be out of here in half an hour. So there was something in the change package, in the theory of change, around a more horizontal relationship between the woman and her clinical team. So it was a number of things. And undoubtedly, on the second phase of this work, we included tangible work with insurance companies. And there were some incentives and disincentives that worked a little bit to aid all of the other drivers around teamwork, around physical spaces, around changing dynamics between the woman and the clinical team. But it was grounded on what the local leaders said needed to be done, rather than on a guideline from abroad. And it wasn't fast. It's a slow process because it's a cultural norm. And sometimes it takes tens or hundreds of years to get us to places, and we expect change in 6 months. And it doesn't happen that way. So you have to give these things a little bit of time. to start to build movements, both of professionals who now commit to a different reality and of women who feel like their needs and wishes can be respected. And I'll share one last story. One of the leaders of one of the national bodies of professionals came to us after the first 18 months of work, where a number of the hospitals had significantly reduced the C-sections. And he said at the final celebration event, he said, "Can I say a few words to the attendees?" And he got up and said, "I've been practicing for about 30 years. And he pointed to the 500 people in the audience from the over 25 hospitals. You have showed me that my practice has been well-meaning but wrong. And I am committing to you here and now that I am going to change. Even at my age and the stage of my professional career, I am going to change." And of course, Ulfat, when you have a senior leader expressing that humility, that desire for change, that connection to his colleagues, you know you're doing something right.
You highlighted so many best practices here in quality improvement, the shared decision making. You also touched on professional humility, having the ability to critically look at one's own practice. So, just some really well rounded lessons for quality improvement. I'm also going to add, I thought that the 40,000 words I learned in medical school from my medical dictionary were exhaustive, but I learned a new word today, unnecessarian. I'm going to add that to my medical dictionary here. So thanks for sharing that perspective as well. So as part of your work with the Institute for Healthcare Improvement, you coach senior leaders and teams on large-scale change management, patient safety, and quality improvement. And as part of this work in Brazil, I read that you had about 13 hospitals that worked with your team over a 20-month period to implement strategies to reduce C-section rates. So what were the overall results of this project, and what were its successes that continue to be sustained?
There were reductions in the rates of C-section, and that is important. Overall, the reduction was close to 30%, which is pretty significant given their starting point. I would say that for me, the deeper changes came from a policy perspective. The agency were able to progress some pretty definitive moves to changing the norms, changing the guidelines in much more of a professional and hospital-centered way, while still being quite disciplined about the kind of directionality of moving the institutions that were regulated by them to a much better state in terms of C-sections. I think the deeper changes also included how professionals now view the work of birthing, including the multidisciplinary nature of it. There's a lot of work to be done, but I think that the fact that there's an ethos of teamwork and multidisciplinarity is a shift. And there were two more. One was women and hearing their voices and considering their voices as at least equals, if not the guiding voice in the process. And the last one, and this is quite important, is the use of data. Absolutely beautiful to see clinical teams looking at data over time, understanding variation better, and having learning conversations about the reasons for that variation and the importance of local decisions in moving the data to a better place. So those were pretty profound changes, and we must not forget we're on a forever commitment to improvement. So it might be that you move from improvement to assurance. So you instill it in the local policies and guidelines and so on, that you move that to control. So you make it part of your operational plans and you expect them to be at a certain level of performance. But the kind of improvement lens to learning, to innovation, to treating each other respectfully and so on, is a forever journey. So our hope and our dream when we started this work is that within these institutions, teams would continue to behave in an ever improving way with each other to be able to do ever improvement work in service of better outcomes for and with women and babies.
And you mentioned the importance of data, and that is so true. And especially in this project and in many other similar work, segmenting data to look at differences in the private sector, the public sector, or in different populations is really helpful. So in this particular project or in this particular area, the private sector has the highest rates of C-sections compared to the public sector in the environment that this project was based in. And concerns about legal liability can lead to physicians opting for C-sections, even when they might not be medically necessary, as you mentioned. So, what were some of the biggest challenges you faced during this project? Every quality improvement work has its roadblocks and hurdles. So, let's talk about that for a bit. So, think about aspects that didn't work as well, or a specific instance where you had to adapt your approach or your strategy to address an unexpected challenge.
I think there were probably two massive challenges. One was the financial equations. It's hard, it's hard when you can do 8 procedures in a day versus two, and the system rewards you in a way that you're basically being able to double or treble what you make in a day. That's really hard. And we had to work very hard with insurance companies and with professionals to get to a place where it didn't feel like their income was being hit so hard. So that was super complicated, actually. And it continues to be, frankly. So the financial incentives and disincentives is a massive challenge. The second is the kind of mindset of norms that are established in terms of one's own practice. So if you have not done a natural birth for 5 years, it would be just natural for you to be slightly nervous about going back to doing something that you haven't been doing. So how do you get people into simulation rooms to start to experience again the emotions, the feelings, the practice, the touch required to deliver babies naturally? So there was a lot of effort into simulation for sure. So those two challenges were probably amongst the biggest. And the last one is time commitment and time constraints versus time efficiency. And again, when you can schedule things, so Ulfat, you come at 9 o'clock on a Monday and by 9:45 you'll be out, versus you come at 9 o'clock in the morning and then at some point in the day or the day after you'll deliver your baby, it becomes a challenge for both parties, for the obstetrician and the clinical team, because they can't predict when they'll start, when they finish, and for the women who maybe had family members who told them about their experiences and they did not include waiting 12, 14, 15 hours to deliver their babies, but rather a quick in and out procedures.
And you did this through, iterative learning and listening to people that were the front lines of care. And talking about learning, we started off this conversation with how your sports background really paved the path to your entry into the world of healthcare and your psychology background and your global work. So let's talk about that a little bit. So you've been an international professional footballer, I heard, soccer for my colleagues in the US. So tell us a little bit about your football career and what are some lessons specifically that you learned from being a footballer that you apply to your work in quality improvement?
Footballing career. Well, I'll give you a headlines. I'm rather shy talking about it, but I had the chance to play for the under 17 national team. I had the chance to play kind of professionally in a couple of countries, and I had the chance to play under a full scholarship in the US. It's called the NCAA Division One school, and I feel super lucky, because playing a sport at that level, it's a combination of course, self-discipline, but most importantly, teamwork. And the biggest learning from me is the joy of working with other people, understanding each other, competing and cooperating at the same time, having a shared purpose, having shared objectives, shared aims, supporting each other. It's a beautiful analogy for life. So teamwork is probably the biggest lesson for me. Second, humility. You become us as opposed to just me, and you create a set of interdependencies that make things work. And when you work in a team, when they work, it feels beautiful. It's very nice, and it kind of reflects on not just the winning and losing thing, because that's the third lesson for me. Life is not about winning and losing. Life is about learning and taking the opportunity that you have every single day when you're training in a high performing sport to be better and to become better, and taking the opportunity that you have every single week when you play matches and either win, lose, or draw, to take the learnings from how your performance went to enhance how you do it the next time. So those three things for me are fundamental. And the last thing, which I would encourage all of us who work in healthcare to do, is the opportunity that we have to do what we do seriously and put a lot of time and effort into it, which we all do, but also to try to do it joyfully.
So those, Pedro, are some beautiful lessons from the beautiful game that I and listeners are going to carry with us. So, we wrap up each episode by talking a little bit about the country or place our guest is connected to. And you've worked widely in Latin America. This particular project we discussed today was based in Brazil, but you've also worked in Chile and many other parts of Latin America. You yourself grew up in Venezuela. So, what's one place or experience you enjoyed there that a new visitor to Venezuela should check out?
Oh, that's such a hard question. I have like 10. So I'm just going to give you one, only because it made me feel like I was absolutely insignificant in comparison to nature. And we are really, honestly, we are intruders in the beauty of nature, you know? So the place is called the Angels Falls. It's in the jungle. It's the highest waterfall in the world, about 1,000 meters high. So it's very impressive when you go, but when you're there, there's no buildings, there's very few houses, all of which are built by hand. And you're just a little something walking around a massive something, which is nature. And you get to be grateful for inhabiting the world that we inhabit. You get to be grateful for the wonder of a clean river, the wonder of clean air, the wonder of natural habitats that have a richness in fauna, in flora. I mean, it's incredible. So if you ever get the chance to go to Venezuela and you can get yourselves to the jungle and particularly to Canaima, which is where the Angels Falls is, just do it. For me, it was a trip of a lifetime.
Yeah, and the magnitude and the size of the Angel Falls, as you described, really sounds humbling, similar to much of the work that we do as quality improvers. So, those are all the questions I have for you, Pedro. It's been an absolute pleasure talking to you today and learning from you, and I thank you for your time.
Thank you for the opportunity to be with you and for the work that you're doing by promoting conversations. I think in the world that we inhabit, the more dialogue we have, the more shared understanding that we create, the better off we're going to be in terms of our social climate. So I really appreciate it.
So that was Pedro Delgado telling us about initiatives to reduce C-section overuse in Latin America. In the United States, people of color and those who are poorer have higher rates of unnecessary C-sections, and this gap is widening. So with all these complex drivers, what can be done to reduce unnecessary C-sections, and what steps are effective? It requires a multifaceted and tailored approach. The World Health Organization has guidelines on non-clinical interventions specifically to reduce unnecessary C-sections, that include patient education and support during labor from midwives, doulas, or other skilled health workers. Interventions to change health professional behaviors could include audit of practices and timely feedback on clinical approaches, coupled with on-the-job training and skills development. Interventions to change health systems could include collaborative practice models where midwives work with obstetricians, changing financial incentives that reward overuse, and creating adequately resourced labor and birth environments. There's no single solution to this complex problem. It's also about striking a delicate balance, ensuring medically necessary C-sections are accessible while actively reducing overuse, all while respecting women's rights to choose and promoting informed decision-making. The goal is to move toward a world where every woman has access to the right care at the right time, ensuring the best outcomes for both mother and baby. Thanks for tuning in. This was your host, Dr. Sheikh. You were listening to Mapping Healthcare on KDRT 95.7 FM. Please connect with the show on Instagram at Mapping Healthcare to share your thoughts and ideas for future episodes or guests. You can hear Mapping Healthcare around the world anytime on kdrt.org and wherever you get your podcasts. If you enjoyed this episode, please don't forget to subscribe and leave a review.